Good evening, everybody. My name is Dr. Mike Blaney. I'm one of the surgeons here at Live Healthy MD, and tonight we're trying something new in our practice, which is utilizing modern technology to webcast a webinar to attempt to educate our patients and answer questions for individuals in our community who may be suffering from the disease of obesity. Just wanted to introduce who we have with us tonight. Dr. Ed Boland is on the line. He will be taking questions and answers from our patients. Ed, can you say hello?
Hello, everybody. I hope you can hear me.
So we also have Bryn Hamilton, our dietitian, on the line. Bryn, can you introduce yourself?
Hello.
So a little about myself. Like I said, my name is Mike Blaney. I've been in the community here for the last 12 years. I went to Military Academy for college and did my medical school at Emory Medical School and did my surgical training at Eisenhower Medical Center, and then joined the practice that I'm with here in Augusta. I've been doing weight loss surgery in the community for the last decade. I formed a group called Live Healthy MD with Ed Boland, who's a friend of mine that we date way back in the military together, and he's a family physician who is board certified in medical weight loss as well as family practice and preventive medicine, which really makes his experience unique. And the two of us together, along with our other partners, formed this company, Live Healthy MD, where we're dedicated to trying to help our patients achieve quality of life resolution of medical problems through weight reduction. And Bryn is our dietitian, who I'm proud to say is one of my patients, has done very well over the many years since she's personally had surgery. So she brings a degree of expertise to our practice, not only as a registered dietitian, but also as a patient from a personal perspective. So without any further ado, let me just kind of go down across the console at the bottom. You see on the bottom of your console various widgets, and you can click on those and close them and move them around on the screen. If you want to ask a question, click on the Q&A, the red box on the bottom. If you want to share what we're doing tonight with some friends, please feel free to do so, and you can do that through Twitter or Facebook. And certainly if you want to send us an email and contact us after the webinar for further information, please do so on the Contact Us form. And then lastly, there's a survey form, the one on the far right. I would encourage you to click on that at any point during the webinar and fill it out. If you need to leave early, that's fine. You can do that at any point. Once we get done, this is going to be recorded, so you'll be able to come back and watch this on demand. So we're doing this for the first time, so let's see how all this works. I want to try to break up the monotony of me talking with some videos.
Was really overweight.
We will also have some poll questions as we go through this and try to
the doctors and the staff
get our audience interaction.
You know, I have that energy. I can go out and play with him. I can run. 2 years later after the surgery, I feel great. I feel wonderful. I feel like I could go out and run marathons.
So first I want to do is just introduce who we are. We're a medical practice dedicated to treating our patients to help them lose weight. We're a group of 3 surgeons. Collectively, we've performed a volume of over 5,000 surgical cases with a over 20-year combined surgical case volume. We have 2 primary care physicians in our group. One is Dr. Boland, who's a preventive medicine physician, and the other is Dr. Mary Lou Thompson, who's an endocrinologist. We have 2 nutritionists, Bryn and Trish, a PhD level psychologist, our exercise specialist, Richard, who works in our in-office gym, our nurse coordinator, various patient navigators, and of course our well-trained staff who's dedicated towards helping our patients achieve better quality of life through weight loss. Our office is a 10,000 square foot facility located in Martinez, Georgia on Washington Road, and we're proud to say that we're the only comprehensive facility within this entire region. We have an in-office patient gym, patient accessible rooms, and really what we're most proud of is the classroom, where we really do a lot of education with our patients. All of this comes together to deal with the complex needs of our weight loss patients. So what everybody really wants to know is, how do we lose weight? Well, really, this talk tonight is really meant to be somewhat on the quick and dirty side. We're not going to get into a lot of detail about this, but our patients, when they come through the program, will certainly get a ton of information on what they need to know to not only lose weight in the short term, but maintain that weight loss long term. But really what it comes down to is an individual has to achieve a deficit of calories, and more specifically a deficit of carbohydrate intake. There's no magic pills out there, as much as we wish that Dr. Oz had some magic fat-burning diet plan. It doesn't exist. The only thing we can do is create a carbohydrate deficit. What I like to talk to my patients about really is the fact that our diet consists of a combination of protein and carbohydrates. If you were to look at your diet across a whole week, a month, or even a year, you're eating a variety of different foods, and it's in some combination of carbohydrates and proteins. And what we like to say here is nobody gains weight because they ate too much protein. The individual gains weight because they eat too many carbohydrates. Now, unfortunately, some people do have a genetic predisposition to store carbohydrates as fat as opposed to burning it. The red box on the left is an individual who lives on the lower end of the spectrum. The red box on the right represents an individual who we all tend to hate, because this person is the person that can eat all the carbohydrates they want and never gain any weight. So the bottom line to losing weight really comes down to this. Is to lose weight, you have to be under your genetic threshold for carbohydrate tolerance. And if you're not going to lose weight. And unfortunately, many individuals in our society consume an abundance of carbohydrates through just the diet that Americans eat nowadays, and this has led to the obesity problem within our society. So really the way I look at losing weight then really comes down to a three-legged stool concept. We have to create a deficit of calories, and more specifically a deficit of carbohydrates. So how do we go about doing this? Well, really it comes down to three things. We have to eat less, we have to change our eating behaviors, and we have to be more active. So our approach in all of this is, when we're talking about losing weight through surgery, surgery is eating less part. And although this is a very, very powerful tool, it's not the end-all, be-all. We do have to try to help our patients really change their eating behaviors and their daily lifestyle in terms of activity. So the way we go about doing this is through accountability, through regular follow-up, counseling with our nutritionists, behavior modification with our PhD psychologist if necessary, and of course more informally the support groups. And of course for exercise, we want to try to help our patients start doing activity that maybe they're uncomfortable doing or haven't done before in the past through a supervised exercise program with our trainer and in our in-office gym. So why don't diets work? This is really the main question that we all become frustrated with. Well, the first reason is it's genetics. It just has to do with some people's hormones. And then the other part is that most diets, in my opinion, really ask patients to do things that don't come natural to humans. Diets traditionally ask you to do one of two things: either reduce portions to such a degree that it's not fulfilling, or either eat very low-calorie, low-carbohydrate foods that are just not particularly realistic. So really what we're left with then is not very many good answers. Surgery to us really addresses the main problems people have with dieting, and that's allowing folks to eat in a way that is fulfilling, that they're satisfied with a small portion, and to generally eat the foods that they want to eat without feeling like they're being deprived. But again, surgery is not the only answer. It needs to be coupled with behavioral change and exercise. So as a patient goes through our program, we kind of see this in various phases. when a patient first comes to us, we want to make sure that they're fully educated about all the things that they need to know to maximize their weight loss. And this is what we call the preoperative education phase. Now, if an individual does decide to go all the way and have surgery, then of course they have that done. They lose weight, they begin to recover. We go through a process of advancing their diet from liquids to soft to solid foods, typically a 2 to 4 week period. And then over the next year or two, we like to consider this the weight loss phase, where a person is actively focusing on their weight loss, engaged in the proper eating behaviors, and we are heavily involved during this process of keeping people on track and doing what they need to do. But it doesn't end there. We can't just simply believe that, hey, I've lost 100, 150 pounds and I'm suddenly cured of this disease. We have to maintain that weight loss. And that really is the hard work, is maintaining this long term. The way we do that, really, quite frankly, is just continuing to engage in the behaviors that led to the good weight loss to begin with. And, of course, we're here along the way to keep people on track with that. So, who qualifies for surgery? Well, of course, surgery is not meant for losing 10 or 20 pounds. It's meant for losing a massive amount of weight, typically for individuals who we consider to be clinically severely or morbidly obese. And generally speaking, this is a body mass index greater than 35 with health-related problems or greater than 40. So you can see on the graph here, an individual may be 5'3" tall, 220 pounds, 230 pounds is in that body mass index range of 40. Now, there's nothing magic about these numbers. We just know from large population studies that when our weight becomes in a range greater than 35, health-related problems really start to escalate. If you think about yourself personally, many of you out there may be suffering from hypertension, diabetes, osteoarthritis, etc., and these problems probably didn't become to be too big of a deal until you started to get in that 230 to 240 pound weight range. Now, fortunately, physicians and the community in general is beginning to recognize obesity truly as a disease, and we've known this for a long time, that obesity really affects every part of the body. And as a disease entity, it stands to reason that if we can correct this problem of being overweight, then we can certainly have a positive impact on health-related comorbidities that are associated with a person's obesity. And it's really quite amazing how almost overnight an individual who has diabetes is virtually cured of their diabetes after a gastric bypass. And saw several patients today who are on 10-plus medications who are now off of their medications within a few months after these procedures. So who really qualifies for surgery then? Well, the basic qualifications really comes down to what I mentioned previously, a body mass index greater than 35 with health-related problems or greater than 40 without those problems. And this comes from data that was studied over 30 years ago. But I would add a few other criteria to this whole list. And first major criteria would be, are you healthy enough to undergo a major operation? And although these operations are very safe, it is still major surgery, and we don't want to underemphasize that. But the majority of people that we do see are excellent candidates for these procedures. You need to really feel like you've failed attempts at previous weight loss in the past, and you need to give very careful thought and consideration to this form of therapy. And really that's what surgery is a therapeutic option for the treatment of obesity. And lastly, you really need to be committed to significant lifestyle change. For some individuals, this may be very minor change, and for other individuals, it may be very significant change. Of course, we're here to help guide our patients through that whole process. So
I am Patrice Jackson,
show a little video here to try to break up some of the routine.
Before I had the surgery, I started having health issues. What made me actually have the surgery was looking at pictures. I realized that I wasn't happy. My life now is a lot better. I can run. I am more energetic. You know, it's now like, wow, they're actually looking at me because I'm me. The experience that I had with the doctor and their staff was...
All right. So I think as I've done this for more than a decade now, I hear a lot of myths that I think, quite frankly, scare a lot of people off from considering this therapeutic option. So what I wanted to do was kind of go through a few of these myths. But first, I wanted to take an audience poll and just get a sense of what people really think about this. And then we'll go through the myths, and then we'll review the answers to the poll. So the first question is, my impression of weight loss surgery is that either A, it's very dangerous and that most people have problems after it, or B, surgery has risks, but the benefits far outweigh those risks, or C, there's virtually no risks and anybody should have this done regardless of what their weight is. So you just take a minute, click on the answer, and then we'll move on. Next question. Patients who have weight loss surgery gain most or all of their weight back. Is this never happens? Or B, happens some of the time, only if they eat the wrong types of foods? Or C, it always occurs? So take a minute and check your answer. Next question. To have weight loss surgery, you have to be cut wide open. Is this true or false? Yes, you have to be cut open, or B, no, you do not have to be cut open. Next question. After weight loss surgery, you'll not be able to eat normally. Answer A, yes, you'll be able to have, yes, you'll have to make a lot of changes and eat what you want. I think I messed that up. I'm sorry. Answer B, no, you can eat just like you always have. Or C, no, you can eat what you want, but should modify some of your eating behaviors. What I meant for answer A was, yes, you'll be able to eat normally. You will not have to, I should have said you will not have to make a lot of changes, and you can eat what you want. Sorry about that. That's what happens when I do these questions at 12 o'clock at night. All right, next question. I'm over 65 years old and I can't have weight loss surgery because it's too risky. Is this A, true, or B, false? Then I think the last question I have is, I have a lot of medical problems like diabetes, high blood pressure, heart disease, heart attacks, etc., and weight loss surgery is just too much risk. Is this A, true, or B, false? So let's look at these. These are really just some common myths that we hear all the time, is that number one, weight loss surgery is dangerous. Any surgery of any type has risks. Weight loss surgery really is no more risk than any other commonly performed procedures that an individual might have done. And in fact, an individual is more likely to die from having a knee replacement than to have a gastric bypass surgery. So although there are risks, it certainly is a very safe operation relative to other commonly performed procedures. Next question that we hear all the time, and I'm sure everybody knows somebody that's had weight loss surgery and has gained their weight back. Does this happen? Yes, it does happen. It can happen to anybody. Nobody's devoid of the risk of regaining weight, but it is a rare exception that an individual regains what we would consider to be a significant amount of weight. Most individuals are going to lose a lot of weight, get close to, if not to their goal, and will maintain that weight for the rest of their lives as long as they continue to generally engage in the behaviors that led to the weight loss in the first place. Some of the other reasons I've heard for people maybe not looking into the option of weight loss surgery is that they believe that they have to be cut wide open. Well, 15 years ago we did these operations open through a large incision, and this certainly was very scary to individuals and certainly led to a lot more risk and complications than what we see nowadays. So the answer to my question was, no, it's false. We don't have to cut you wide open to do these surgeries. We do them all laparoscopically with several small incisions, and this really has greatly improved the risk profile associated with these operations. Many individuals think that they'll never be able to eat normally again, and that's not true. An individual who has weight loss surgery typically can eat just about anything that they want. The only difference is that they just eat very small portions and that they feel full and satisfied with that small portion. Now, that's not to say that we would recommend an individual continue to eat ice cream or cookies or foods that are high in concentrated carbohydrates. We certainly want people to avoid that, but they could eat it if they wanted to. Sometimes I'll hear our older patients say, well, I'm too old to have weight loss surgery. This isn't a good idea. There's no absolute there's no absolute age limit. Certainly I wouldn't recommend weight loss surgery for somebody probably 90 years old, but there's plenty of patients who are in their 60s or even in their 70s that have opted to have weight loss surgery and turn out to be excellent candidates and do quite well. So really I think that the question of age really comes down to an individual concern that we need to weigh against the ongoing medical problems that the patient may be suffering from. And then lastly, many patients think that because they have diabetes or high blood pressure or even had a heart attack that they cannot have weight loss surgery because it's too much risk. And I really kind of laugh when I hear that a family physician or somebody has told their patient that they have too many medical problems, that they are just too high a risk. And really, those individuals are the perfect patients to have surgery because these are the problems that we're trying to solve. And it's quite amazing how losing 50 pounds even makes such a dramatic difference in an individual's medical problems. So let's just look at the polls that we had. My impression of weight loss surgery is that surgery has risks, but the benefits far outweigh the risks, and I would agree with that. So everybody got that answer correct. Next question, patients who have weight loss surgery gain most or all of their weight back, and I would agree that this occurs some of the time if patients eat the wrong types of foods. So we've got a smart audience here. Next question, to have weight loss surgery you have to be cut open, and of course we know that not to be true. Although we have to accept the fact sometimes we do need to do surgery open because of unforeseen circumstances. This occurs much less than 1% of the cases that we do. Next question is, after weight loss surgery, you'll not be able to eat normally. And I probably confused people on this question. So the correct answer would be you'll be able to eat normally, but you will have to modify some of your eating behaviors if you want to maintain that weight loss. So I would say that C would be the correct answer. The age question, so everybody got that correct? No, there's no absolute age limit, and these surgeries are a reasonable option for some of our patients who are in their 60s and even 70s. And then lastly, the audience got this answer correct, that an individual who has a lot of medical problems certainly is a good candidate for these operations because these are the people that we're trying to help the most. All right, so moving along. Let's talk about real briefly the different types of surgeries that are performed. And I could sit and talk about this for days, and everybody's eyes would glass over. So I'm going to just touch on the very basics. Weight loss surgery has been around for many decades. As surgeons, we have been trying to find a perfect operation that would affect an individual's weight loss, and I'm here to tell you that that doesn't exist at this point. There is no perfect procedure. Every operation has its own set of risks and benefits, and as a patient goes through our program, we'll certainly get into great detail about all these procedures. Commonly performed operations that are done nowadays are 4 types. It's the gastric banding, gastric bypass, sleeve gastrectomy, and an operation that not many programs perform, but we do here at Live Healthy, is the biliopancreatic diversion with duodenal switch. So let's look at each of these individually. All the operations are done laparoscopically. What that means is several small incisions. We place these small sleeves called trocars through the abdominal wall that allows us to introduce the instruments in and out of the abdomen. We inflate the abdomen with carbon dioxide gas, and we can visualize what's going on in the abdomen. So small incisions really mean a lot less pain, more rapid recovery. Of course, it's cosmetically smaller scars, and much, much fewer wound-related problems. And this really overall has led to a much, much safer approach, and it's been great patient benefit in the field of bariatric surgery. So gastric banding has been around for about 15 years in the United States, and really as an operation is the simplest operation with the lowest risk profile, simply because we're not cutting or dividing any of the stomach. We're simply placing this mechanical device, a silicone band, around the upper part of the stomach, and we adjust this band by injecting saline or water through a tubing that's connected to the band. This tubing is connected to a port that sits under the abdominal wall, and a patient will come to the office, and in the office we will place a small needle through the abdominal wall into the port and inject the water into the port to fill the balloon, and this makes it tighter around the upper stomach, leading to early satiety with eating in smaller portions. Now, because the operation's simple and doesn't involve any cutting, it's reversible, it's adjustable, this leads to a very safe risk profile, and typically this operation will take about 30 minutes to do, and patients will go home the same day. But as anything, there are certain downsides, and I would say, having done this for many years and observed hundreds, if not thousands, of patients with bands, that there certainly is less weight loss than that is achieved with the gastric bypass or the sleeve. And regular follow-up is really absolutely critical for optimal results, and sometimes we're needing to see our patients as often as every month for an extended period of time in order to properly adjust the band. Of course, the band, unlike the other operations, is an actual device that's implanted and is meant to stay inside the body, indefinitely. So what happens with the band over 30 or 50 years is not entirely known. We believe it to be safe to remain in somebody forever, but studies only go out about 15 years that has looked at this. And unfortunately, when we started doing bands in the United States about 10 years ago, we were really hopeful as bariatric surgeons that this would be a very safe and very effective operation. But unfortunately, it has not been nearly as effective as we would like, and I would say a good 30 to 40, 50%, or even as high as 50% of patients just, quite frankly, are dissatisfied with the results that they've achieved and end up deciding to have the band removed. And that, for us as bariatric surgeons, certainly has been disappointing. So moving on, the gastric bypass has been around for many decades and has been really what we as bariatric surgeons to be the gold standard operation for these procedures. We do this laparoscopically. We've been doing it for many, many years in the United States, and really internationally and within the U.S. is the most commonly performed weight loss surgery procedure. If you go to our website, you can watch videos of all of these operations. You can get a better appreciation for how they're performed. But in brief, really what we do is we divide the stomach into two segments, a small upper pouch and the lower part of the stomach that's left behind. And then we reroute the intestine in a fashion so that we separate the food passing from the pouch from the digestive juices passing from the stomach by about 25 or 30% of the entire length of the small intestine. And then it comes together downstream, and that's really where the digestive process begins. So an individual has about 25 or 30% of their small intestine bypassed. So they're losing weight predominantly through portion reduction. They're eating less, but an individual is also losing weight because they're absorbing less of the calories that they ate with a meal. So weight loss tends to be very good. Most patients are going to lose 75% of their excess weight over the first 12 to 18 months. And some patients find comfort in knowing that the surgery can be reversed. Of course, it's not meant to be reversed, but it can be taken apart and the stomach can be put back together close to normal, but it will never be entirely anatomically normal like it was prior to the operation. All right, so the sleeve gastrectomy is an operation that we in the United States as surgeons have been doing for about 10 years, but did not routinely become covered by insurance, most insurance carriers, until 2010. So this operation's gained a lot more popularity over the last 3 or 4 years, and I think by and large because of its simplicity. It's easy to get your head around this operation. We don't do any rerouting of the intestine. All we do is simply remove about 80 to 90% of the stomach volume. The way we do this is at the time of surgery, we place a tube down through the mouth into the stomach, and we use that tube as a guide in order to staple along the tube as we transect the stomach from the lower edge to the upper edge of the stomach and remove that outer portion of stomach that you see in the picture called the excised stomach, and that is completely removed from the abdomen. So obviously this cannot be reversed. So in essence, we've turned the stomach into a long, narrow tube. I'll tell folks about an 8-inch segment of garden hose is about what it anatomically looks like. So a patient's losing weight mostly through restriction. They're eating less volume of food, so they're losing weight that way. But we've also learned that the stomach makes a variety of different hormones, and some of these hormones stimulate hunger. So by removing the large outer portion of the stomach, we're reducing some of these hunger hormones. So an individual typically after a sleeve will tell us that they're just not hungry and they don't feel like eating. Sometimes that can actually be a problem because people aren't eating enough and their weight loss may be a little slower than we would expect because there is a certain amount of food that a person needs to eat prior or in order to achieve satisfactory weight loss. So that's the sleeve. And lastly, the biliopancreatic diversion with duodenal switch, a long name that I'll just call the DS. And really the best way to look at this operation is it's a combination of the sleeve and the gastric bypass, but instead of bypassing only about 30% of the small intestine, as I said before, with the gastric bypass, we're going to bypass about 60 to 70% of the small intestine. So this operation has significantly more malabsorption than the gastric bypass, so vitamin and mineral deficiencies occur with a greater frequency than that with the gastric bypass. But as our parents told us, nothing in life is free. That's true of all these operations. This operation, the DS, has the greatest weight loss and the best weight loss maintenance. So as I tell folks that are considering these operations, really the operations that are the easiest, simplest, typically have the least weight loss, and the operations that have the best weight loss are usually the ones that are a little more complicated. So as the patient goes through our program, we'll certainly get into much greater detail about these operations. So in conclusion, what operation is best or what operation should a patient have done? That's a real tricky question. We need to see our patients individually and help them decide. But generally speaking, what I think is that our heavier patients, our patients who suffer from more medical problems, should probably opt more for the malabsorptive procedures like a gastric bypass or a duodenal switch. Individuals who are on the lower weight or the lower end of the weight spectrum and maybe have less medical problems, certainly a gastric sleeve is usually going to be adequate, and sometimes the band would be a good choice, although we tend to recommend the band less and less these days because of the overall patient dissatisfaction that we're seeing. So in summary, in order to lose weight, I hope I've driven home at least one key point. Surgery is a great tool, but it's not, the end-all, be-all. It really needs to be coupled with good, solid eating behavior that is based on the sound scientific principles of high protein and low carbohydrates. and an individual needs to be more active in their daily life. And when we couple all three of these together, that individual can be the star student in the middle. So if somebody is considering seeking treatment for their obesity, what options do they have? Well, there's always the non-surgical approach through our care with Dr. Boland and Dr. Thompson, who are experts in the field of obesity medicine. And then if medical weight loss fails, then we always have a surgical approach. We like to pride ourselves as a very comprehensive program, one that really wants to focus on every aspect of losing weight, the eating less, the eating right, and the physical part. And unless we really combine all of these three things together, an individual is not going to be nearly as successful as they might otherwise have been. So we've tried to put all this together within our program with our on-site nutritionists who are available all the time during business hours, and they've been known to even be available after hours. Bryn will probably kill me for that. But no, she's online on our support group page and on the Facebook page answering questions at all hours of the night. We have our in-house psychologist, Dr. Connie Stapleton, and our exercise physiologist, Richard Maddox. We have our in-office gym that's available to our patients to utilize with Richard if they so choose in a private environment that will allow them to get started on a program. We realize that many of our patients may not be very comfortable going to a big box gym where they're around other individuals when they're not quite sure exactly what to do or how to get started. Our practice offers a very active support group that Bryn and Trish, our dietitians, take very good care of and run this quite well. And the support group's really an opportunity to learn something at every meeting. So I really encourage our patients to attend these monthly meetings. We're available to our patients really at all times, and we're answering questions either online, through social media and whatnot at all hours of the night. And as bariatric surgeons, myself and my other two partners, Dr. Hakame and Dr. Glass, we perform all of these operations because we really believe that one-size procedure doesn't fit everyone's needs. And it's very important to be able to offer our patients a variety of different options because one size certainly doesn't fit all. Lastly, we're a center of excellence, which really means that we've performed a volume of cases and achieved a certain level of standard that is recognized by our national medical society called the American Society of Metabolic and Bariatric Surgery on a hospital level. Trinity Hospital, where we perform most of these operations at, have a dedicated bariatric staff and committed nurses that really understand the needs of our patients. So, what's the truth about surgery? It's very successful, works very well for the vast majority of patients, but it's not perfect. It really requires your involvement, continued follow-up and care. The overwhelming majority of patients, I would say, are very happy and healthy. And really, I hear this almost every time I'm in the office seeing patients. There's usually one or two folks that will tell me, I wish I did this 5 or 10 years ago. And as a practice, we're going to be here with you. We're not going to do surgery on an individual and say, okay, see you later. Call us if you need us. We're going to be here holding your hand for years to come. So, if you have questions, please submit those questions online, and Ed, Dr. Boland, and Bryn, our nutritionist, will be happy to answer those questions. I would encourage you to go down to the bottom of the console, and on that red tab, on the survey tab, click on that. And please answer those questions and give us some feedback. This was the first time we've ever performed this type of venue, and we'd like to know if you found this to be helpful and convenient. Certainly, if you would like more information about weight loss surgery or would like us to contact you, please enter that information in the box on the survey, and one of our staff members will be happy to call you. And we hope to be doing these webinars on a regular basis, pushing out more information to our patients on various topics such as medical weight loss and eating properly and exercise. So please make sure we've got your email address, and we encourage you to please share this information if you found it helpful with friends and family members or people who maybe need that help and don't know where to turn and have been suffering from their medical problems and their disease of obesity and really just don't know where to go. Many times patients are just too embarrassed to ask for help, and that's what we're here for. So we hope you all had a good night, and we look forward to hearing from you in the future. I'd encourage you to go to our website, livehealthymd.com, and if you want more information about the procedures and look at the videos that we have online. I'm going to stay online for a little bit, but I'm going to disconnect from the audio, and we'll be answering questions for the next 15 or 20 minutes or so. Everybody have a good night, and have a happy Thanksgiving and Merry Christmas.